a question and answer session. So really quick, first question. I'm 62. My prostate is slightly enlarged and growing into my bladder. If it's not needed, why not have it removed? Is there a negative fallout from that?
Yeah, so we remove the entire prostate when people have prostate cancer that warrants removal of the prostate. When a prostate is removed, again, by virtue of its very unfortunate position in the body, it can affect urinary continence. So people can have troubles holding their urine, at least temporarily, sometimes long term. And it can affect sexual function, ability to get erections and beyond. And so we don't uh, offer removal, elective removal of the prostate if it's not cancerous and not even for all cancers.
Okay, great. Another question that we have is I heard that there's a new test better than the PSA test, and it's a PSE test. Is there any validity to that? And can you comment on that?
Yeah, there are, and the PSA, is a test that we use to try to screen for prostate cancer. And I always say the PSA is the best terrible test that we have in medicine because it's not specific to prostate cancer. It's PSA, it's prostate specific antigen, not prostate cancer specific antigen. So there's a lot of reasons why PSAs can be high, including a big prostate. Some people run big, et cetera, et cetera. So not all elevated PSAs are because of cancer, and not all elevated PSAs need to get a biopsy. And so the PSA is a good starting point. And oftentimes in our practice, once somebody comes in with an elevated PSA, we offer secondary tests. And there are lots of those secondary tests. There are blood tests and urine tests. And I don't anchor on one test or another because again, they all have similar results and similar, they all play a specific role in the patient's journey. But usually we get a sort of a second opinion on the PSA by doing a secondary test, whether it's a ISO PSA or it's a PSE. I'm not familiar with that. I don't know what that is, but there's probably a lot of these kinds of tests that are offered. I tend to use some urine markers that look at the genetics within the prostate to sort of predict the presence of cancer. And then, then we, beyond that, we combine it with MRIs and other diagnostic tests before we go to a biopsy.
Great. Thank you, Dr. Sarram. Can you talk about any Alzheimer's risks with taking Flomax or tamsulosin?
Yeah, uh, it's almost impossible to establish, to prove a cause and effect relationship. Uh, a lot of men, as we get older, are on tamsulosin, and a lot of men develop Alzheimer's and other neurological disorders. And so, these are observational studies, and there's really only one or two where they observed that people who were on tamsulosin, also, had dementia. And the question is, well, did they just get old and they were on tamsulosin because of the prostates and they got old and they got dementia? Or did the tamsulosin cause that? And there's no way to really design a study to prove that. So, we talk about it and we tell our patients that, hey, long-term medications, remember that consumer report cover that I showed you, long-term medications are, questionable. And if you have to take it, like let's say you have, whatever heart disease and you have to be on a medication to save your heart, of course, you take it. But if you have the option of fixing the underlying problem, BPH, and not have to be on a medication, would you or would you not? I mean, I personally would. And, currently I take, again, I'll share, I take a cholesterol medication, just like a lot of 50-some-year-old guys do. And if I had a doctor who told me, hey, listen, there's a procedure I can do that makes it so you don't have to take this cholesterol medication for the foreseeable future. You may have to be back on it in 3 years or 5 years, or maybe never. Would you be interested? And for me, it's like a no-brainer. Of course, I would do a procedure so I don't have to be on a cholesterol medicine. And so it's a similar idea with prostate medicine. There is a way for us to fix your problem. And of course, I'm speaking as a surgeon, but we became surgeons because we wanted to fix things. Otherwise, we would be plumbers. And so, yes, it is a risk to, not a risk, but it's undesirable to be on these medicines long term. And there's a fix available as an alternative.
I had a bunch of people ask, this is a good one. How do you know how many grams your prostate is? Is that something we can request at the time of our evaluation, or how do we know our size?
Yes. Yes. So when we do that ultrasound, remember I showed you a picture of the ultrasound with the prostate protruding into the bladder. At that time, we can actually measure the size of your prostate. And it's ultrasound that we do, in our offices. So you don't have to go anywhere else, and it's done through the abdomen, so it's not invasive, and it gives us a lot of information. So yes, when you see your doctor, if they haven't offered it to you, you can certainly ask about it.
Okay, we've got a couple more. If your PSA number has increased over time, like over year to year, does that indicate something different than if the number just has a rapid increase in 1 year?
Yeah, we're allowed, as we get older, we're allowed to have gradually rising PSAs. And there's a concept called PSA velocity, meaning how quickly is the PSA going up. And a PSA change of, upwards of zero point 0.7 per year is thought to be acceptable and probably due to aging and enlarging prostate. But if you have a PSA that changes rapidly in a short period of time, first of all, always get it repeated, because we can have bumps in our PSA for various reasons, including sexual activity. So whenever you have a PSA test drawn, make sure you haven't had any sexual activities for about 24 to 48 hours prior. And also, things that irritate or inflame the prostate, sometimes laboratory error, whatever reason, viral illnesses. There's a lot of reasons PSAs can bump. And so a one-time rise in PSA is relatively meaningless. It's notable, but it needs to be confirmed. And so I always say, wait a few weeks, wait a month or two, get another PSA. And if the number truly is, significantly higher than before, that's when you need to come see us.
Does taking HRT for low testosterone have any effect on the prostate?
It's controversial, but yes, prostate tissue grows in presence of testosterone. And so if you have a very low testosterone and then you get on testosterone to normalize your testosterone, it can cause a appropriate growth in the prostate. Now, testosterone replacement therapy is a whole, 2 hour long conversation, whether it's needed or not, and what levels, etc. But yes, if you're on testosterone, it's a hormonal organ, and it can respond to it, and it can grow in presence of testosterone.
If a minimally invasive procedure lasts 3 to 5 years, is it common to have another minimally invasive procedure done? Like, would it be the same procedure, or do you have to then have a different type of procedure? So, for example, how many procedures can be done for a 70-year-old man?
The answer is yes, right? So the good news is there's so many different options. So if you have a minimally invasive procedure and it wears off, potentially you can have the same procedure, or you can have, you can choose from a different procedure on that menu of options, depending on the size and the shape of the prostate. But a lot of it also depends on sort of the size and the shape of the prostate and the severity of symptoms. And then at some point, it also gets a little bit silly, right? We're spending your money, we're spending Medicare money, and each one of these procedures is expensive, and so do we at some point say, let's just go and do the definitive treatment that we know is going to work best and give you the longest results? And so in my practice, I usually don't put more coins in the same broken slot machine. So if one doesn't work, I usually move to something else. Or if it quits working altogether, then we just go for something more definitive.
Great. We will ask just a couple more. I know that you touched on the herbal supplements, but do you have any comments about prostagenics or any recommendations about beetroot since they're advertised so heavily?
No, not at all. As a urologist trained in the Western sort of system, I have very little knowledge or training in what we call phytotherapy or plant therapy, natural supplements. Uh, so I really can't really give you a good opinion on that.
All right. And for the last question for the evening, and then we'll wrap up for everyone. Um, can the beads of the PAE procedure be passed into your system and create any sort of damage to other parts of your body?
Once they are implanted and placed in the right artery, these are end arteries, meaning that they end at the organ. And with the prostate, they are truly the end of the road. And so once you place the beads there, there's nowhere for them to go. During the implantation, if the tip of the catheter is misplaced or goes elsewhere, and before they deploy the beads, they can potentially deploy the bead into a place that they don't want to deploy. And that is a known complication of this procedure, exceedingly rare. And it really is, dependent on the experience of the radiologist who does the procedure. Again, at Colorado Urology, we have two excellently trained folks who have probably, one of the largest experiences in this part of the country and perhaps nationally. I think Dr. McClellan, our partner, just surpassed his thousandth procedure. That's a lot of procedures and a lot of experience. And so, when if you choose that procedure, just like any surgery, pick the person who is experienced, pick the person who does a lot of them, and speaks capably of the procedure.